Pleasure. Thank you guys for having me and sharing your lunchtime with me. So I'm a pediatrician, as mentioned, at the University of Massachusetts. I'm a professor of pediatrics and I run a foster care clinic, but have spent the last part of my career doing a lot of work around child trauma, understanding trauma. And what we're going to be talking about today actually has to do a little bit more with caregivers. So let me pull up my slides here and we'll get going. Let me close off all these boxes. I do have to disclose that we have a book that I have royalties from AAP Press for, a book about trauma and resilience. So what are the learning objectives? That we're going to compare the affiliate response to stress to some other stress responses. We're going to identify 3 ways the brain changes in the human caregiving network, plus we'll talk about what that is. We're going to talk about 5 characteristics of disrupted caregiving, and we'll talk about what that is, and implement 2 specific strategies to develop caregiver and child sense of safety, connection, and reward in caregiving and promote recovery from trauma. So certainly, you guys have been talking about how trauma impacts children, and when you are talking about trauma, it's very helpful to take things back to understanding, why do we see trauma, and it really starts with the stress response. You guys know most of this, that when we're under stress as humans, we have a number of responses. We have the freeze response. We can just stand still, hoping that the predator or threat goes past us and doesn't notice us. As humans, it's not our best bet. We're kind of big, we get noticed. So from an evolutionary standpoint, we had to move on. That's the most primitive response. So we evolved to have fight or flight as well. Good, we can run away from the threat. We can try and fight the threat, but we don't have claws. We can't hide underwater. If you're a child or you're pregnant, you're not going to be particularly good at fight or flight. So again, if that was the only options left to us as a species, we probably would not have survived as well as we have. So humans actually had to evolve to have a much more effective stress response that works best for humans. And what humans have going for us is our big brain and each other. And it turns out that the most effective stress response in many circumstances is the affiliate response, which means that we turn to each other and we say, hey, can you help me deal with this? And that response is also called tend and befriend. It's mediated by oxytocin, which actually makes you more socially salient. You get better at recognizing who will help you and who won't help you. For our kids that we are talking about who have experienced adversity and trauma, what we are really talking about is the fact that they have turned to their caregivers or the people who are supposed to be there to help them and support them. They're safe, stable, and nurturing relationships, and they're not so safe. They're not so stable, and they cannot help them in those moments of stress or threat, which for childhood is most of the time when they're hungry, when they need their needs met, or when there's truly something very frightening happening. When they turn to those caregivers and they can't get that support, they cannot use the affiliate response, they actually have limited options then. And so they get shoved to having to overuse freeze and fight or flight. And as pediatric providers, we know that turning on of the fight or flight response leads to adaptations that are very useful in the short term. They allow kids to survive in these threatening circumstances when they don't have those affiliate supports to help manage them. But we also know that they have long-term health consequences. Certainly for kids, we mostly see this in terms of development, emotional regulation, mental health. We see impacts on immunity and endocrine systems. As people age, we see more impacts on the cardiovascular system, the GI system, the metabolic system. So we know that kind of constantly being under threat is going to, over time, lead to a number of health consequences. I would suggest that for those of us in pediatrics, we're seeing a lot of diagnoses that are profoundly impacted, caused by early significant relational trauma. And what that means is that this is early significant relational loss of affiliate response, the loss of the ability to turn to others who are supposed to be there for you and help you manage the threat. So I think for us as pediatricians, we really want to think about how do we avoid kids having to get shoved over to freeze and fight or flight? How do we help kids to have the opportunity to use the affiliate response most effectively? And this is why we've really shifted how we talk about this. that it's not about summing the suffering. It's not about counting up how many bad things have happened to people, as is suggested by a lot of the ACE screening kind of protocols, but it's really about building the buffering. It's thinking about what is it that we can do to promote these relationships that provide that affiliate or tend to and befriend support. And ultimately, what we're trying to do is help kids to become what we call resilient. Some people have sort of taken, they decided that that term is kind of loaded. And so I'm using it as a placeholder. We might sort of agree that we want to come up with a different term, but for the sake of the discussion, let's use resilience, because what we're talking about is what are we trying to achieve? So with whatever we call it, Ann Maston defined this as this dynamic process of positive adaptation to or in spite of adversities. And for kids, she identified that these pathways to resilience are rooted in the give and take of safe, stable, and nurturing relationships that are continuous over time. We would call those attachments. And for kids, what it means is that during play, exploration, and exposure to normal activities and resources, they have affiliate supports. They don't go into fight or flight. They get that from their safe, stable, and nurturing relationships. And so what we find is that over time, kids are building certain skills that are part of this resilience. And Ann Maston defined what those skills are. I am unusually and probably unhealthily, I love mnemonics. So we created a little mnemonic that what we're doing over time is we're building resilience through threads. We're building that thinking and learning brain, a sense of hope or optimism for the future, the ability to regulate or self-control yourself, and efficacy, meaning that belief that you can impact or have a positive impact on the future. Those attachments or those connections to those safe, stable people in their lives. And all of that allows for this developmental skill mastery, the development of the lower brain and then eventually the higher brain. For most of the kids, it's not just single relationships, but it's this greater social connectedness that also is a part of what's necessary for resilience. Having more affiliate supports so that in times of stress as kids age, there's a wider group of people that you can turn to for tending and befriending. So if we are saying our big job then isn't counting up the bad things, it's about building the buffering, not summing the suffering. What we really need to do is explore those safe, stable, and nurturing relationships and kind of get to the bottom of what's going on with that. And so again, I sort of take us a little bit back to the science, right? So humans are born with a huge amount of development to go. So when I was in medical school, I had a professor who said, you know, the human baby is only born at the 9 months because the human baby has to get through the female pelvis, and it's at 9 months. It's the maximum amount of time. Other than that, the baby is completely undercooked. And that's really true, because when we compare a human infant to an infant of any other species are born with many more adaptive capabilities, right? So the giraffe comes out of the mommy giraffe, it falls to the ground, snapping the umbilical cord, and immediately gets up on wobbly legs, walks over to mom, asks what we're having for lunch today, is able to eat solid food and communicate and do all the things that a giraffe should be able to do. But a human baby, wow, we are completely not ready to go, right? Like the baby is completely dependent. And so actually, in order for a human baby to be born from the womb and have that be the way that we birth infants, we had to have a whole host of neurohormonal impacts on the pairing of the caregiver and the child so that the child could grow up in a healthy way. And what happens is this constant process of meaning making for the child, right? So from the very first interactions that the baby has with the caregiver, the child is coming to understand themselves in the world through these minute-to-minute interactions. The child is reflected by the caregiver and the world is interpreted by the caregiver. So for instance, when the baby cries and the caregiver picks up the baby and says, "Oh, baby, you're hungry," the baby is learning, oh, this feeling I have, that one's hunger. And they're learning that people help me when I feel this way. And that the world has problems, but they also have solutions to these problems. And there's people that help me solve it. And I can communicate what I need, and I am worth being helped. When that baby is a toddler and they try to do something and they're frustrated, the caregiver says, hey, buddy, looks like you're frustrated. Let me help you. And the child learns this feeling's frustration. People help me. I have a way forward. I'm worth helping. I can communicate that. Compare that to kids who have caregivers who are overwhelmed or dealing with their own challenges. And when that baby cries and the caregiver says, oh, you are so damn greedy, would you just shut up? That baby learns this feeling is being greedy. And there's no solution for that. And nobody helps me. The world's not manageable. I can't communicate what I need. And I'm probably not worth helping anyway. And when that baby is a toddler and the caregiver says, instead of, hey, buddy, you must be frustrated, says, what, are you stupid? You can't figure it out? That baby learns this feeling, that's being stupid. When you're stupid, there's nothing you can do. There's no way forward. There's nobody who helps you. You're not worth helping and you can't communicate it. So what you see is that you are relying on this incredible dyad for the caregiver and the child to really be in sync with each other. And again, with the mnemonics, what we call those steps of that is the ABCs. And the A stands for attunement. Attunement is that caregiver being in tune with the child's emotional state, being in it with them. And that child then feeling that they are understood in that moment, that that caregiver gets me and they understand what I need. The B stands for biobehavioral synchrony. Now, officially, the definition of this is coordination of biological and behavioral signals between social partners during periods of social contact. And this is important because we as humans crave biobehavioral synchrony for our whole lives. You notice it most as a caregiver is lovingly interacting with an infant, but you know what? We as adults are looking for those moments of biobehavioral synchrony in all we do. When you have the most important relationships and you're really communicating, or you're dancing, or you're in connection with someone, you know it because you are feeling that biobehavioral synchrony. But this is built into our neurology because this is the mechanism by which a parent's mature brain externally regulates that infant's immature brain and tunes it in to social life. You know, it's very interesting because the studies have been done on traditionally maternal and traditionally paternal types of synchrony, and they are a little bit different. Traditionally maternal synchrony is really about vasoaffective of connection, right? So the voice and the emotion are being shared. The infant and the mother look at each other and they match. She matches the baby's mood. Oh, baby, are you sad? She does it with the tone of her voice. And then the baby vocalizes, and the maternal, doesn't have to be female, but the maternal character usually matches that. And interestingly, when we look at what we see in children who have had the opportunity for maternal synchrony, is that we see that by age 2, these kids are much better able to regulate themselves. And that in adolescence, they are much better able to connect with their peers. That is different than the synchrony that is traditionally seen with paternal characters. You can imagine that in this picture, this male character is not going to kind of go goo-goo with this child, but might lift her up and drop her down and bounce her along. That synchrony is more typical of what have been traditionally paternal synchronous. They're much more positive interactions that are kind of short and positive and externally focused. And interestingly, when we see that a child has had synchrony with a paternal relationship, we notice that they are much better in adolescence at managing conflict with their peers, that they are much better at engaging and helping the others in their peer group to manage conflict as well. They're also much less likely to have depression or externalizing or internalizing behaviors. So really very critical pieces of our human development happen in these synchronous moments. And what is actually happening is the C of ABC, that there's this co-regulation or dyadic co-regulation. So what we're talking about is that there's a stepwise process for kids to learn any skill. The caregiver has to regulate themselves. Then they have to pair with the child and they have to kind of help the child to do it. We do this with like picking up toys, where we first pick up the child's toys and then we sing the silly song, clean up, everybody clean up. And we hold the child's hand and we pick up the toys together. And eventually the child is able to do it. We can say, go pick up your toys. and they go do that. That's that kind of the equivalent of self-regulation. So it's this stepwise process by which an infant is moving in this developmental process. And so what we see is that humans develop sort of primarily from this, the role of oxytocin. And as I mentioned, oxytocin is the critical hormone in the affiliate response. And that organization of oxytocin's availability at the limbic and neocortex areas of the brain depends on early caregiving. And it leads to selection of stimuli to promote that dyad, right? So that caregivers and children find opportunities to connect with each other. And we're going to talk more about that. What that leads to is this biobehavioral synchrony, where the early environment then exerts effects in coordinating the biological and social processes during social contact. You know, when that mother is in that synchronous relationship with her infant, the heart rates line up to within 1 second of each other. When caregivers are in sync with children, we see cortisol levels going up and down exactly in concert with each other. It is not just matching of kind of thought or attitude or even emotion. It is a matching of true biologic functioning. What's interesting, though, is that this happens and that in sensitive periods, we see the development happening, right? So you change the balance from excitation to inhibition. You have this increasing preference for selective inputs, and eventually this development of the brain from a lower to higher mechanisms. So now you're saying, you know, that is super interesting, Forkey. And that is kind of what I already knew because I'm a pediatrician and I study children. But I think what we really haven't learned in pediatrics is an understanding of the other side of the dyad, right? That the caregiver's ability to attune, to have that biobehavioral synchrony and to co-regulate. What does that come from? Because I have to tell you, we used to think that the baby having just big eyes made the parent sort of want to help that child. Of course, that's not nearly enough, right? So what we now understand is that there's a huge amount of neural network changes in the plastic human brain such that the brain alters so that the caregiver can do this work. And that those changes happen to different parts of the brain, which all together are called the human caregiving network. In specifics, what we see is some changes to the orbital frontal cortex supporting rapid orienting in response to infant cues. You know this because, so for instance, I would go to the grocery store with so I have 5 kids. One of my oldest child just had a baby. I have a couple of adolescent sons. And if I go to the grocery store with my adolescent son and my daughter who just had a baby, and we hear a baby crying in the distance in the store, my daughter who just had a baby can't think of anything else. Like, where's the baby? Why is nobody picking up the baby? She is incredibly oriented to hearing that noise. I hear it. I definitely notice that a baby is crying because I have been attuned to this. And my son, who's an adolescent, says, what? I don't hear anything. His brain hasn't gone through this. He has not had those changes in his frontal cortex supporting that orienting. We also see changes in reward pathways, which rely on dopamine and oxytocin. And I'm going to talk more about those in a minute, because after all, parenting must be rewarding or we won't stay at it. Because it is not fun. It is objectively not fun to stay up all night with a baby who's crying, unless you find an enormous amount of reward when they finally smile at the end of, after 12 hours of crying straight through. These gray matter increases and changes happen with pregnancy, but also with child rearing, and they are associated with positive perceptions of parenting. I mentioned to you this changes in reward pathways, and in particular, what we see is changes at the nucleus accumbens, which is the reward center of the brain, and the ventral tegmental area, which is the part of the brain that produces dopamine. Massive changes in those areas that increase the response and the stimulation that parenting provides. I want to point out that this happens not just in moms, but in dads as well. It happens to people who parent from a biologic parenting, but also people who foster parent or adopt. And what's interesting is that it appears to happen due to neuroplasticity that's being changed by the experiences and the cues from the other people in the dyad. If it's a dad, you're seeing changes because there's a mom and an infant that are stimulating those changes in his brain. And so this is a global network of parental care. It's a global set of structures that change. It's not just unique to to one gender or another. Ultimately, there are 5 systems that need to change so that this can be done. And again, pathologic desire to make mnemonics, I created a little mnemonic so we can remember what they are, and I call them the fibers, right? So you have to feel safe being close to the child. You have to have a sense of safety. You have to believe that you are in a safe space so you can care for the child. You have to have this reward, this implicit reward and pleasure from interacting with the child. You have to have beliefs that you can do this, that you have affirming stories and narratives that you are good enough to keep doing this job. You have to have executive function, which is controlling those uncaring reactions so that you can stay the adult in the room. And I'm going to guess that many of you have been in circumstances as a caregiver or parent where you have really not wanted to be the adult, but you were able to, with the executive function changes, stay the adult in the room. And then finally, the critical piece is that the caregiver has to be able to do this reflective functioning or attune to kids' inner lives using empathy. Another one of the parts of the brain that is profoundly impacted is the anterior cingulate cortex, which is the empathy center of the brain. Particularly in males, there's a massive amount of change that increases empathy to allow people to, again, want to reach out to and help this infant. So for those of you who are the neuroscience geeks in the group, I have in my slides exactly which areas are changed in order for these different fibers to develop. But suffice it to say that we can think about the changes as having to be critical in terms of fear versus safety, implicit reward, the belief that you can do this job, executive function, and reflective functioning. So then we begin to think about the situation, what if a caregiver has experienced trauma or depression or substance misuse? And the reason this is important is because I'm sure you've had other lectures which have indicated to you that the brain is changed by trauma, right? So if you're shoved to fight or flight as a child and you have changes in your developing brain, we see changes particularly in the anterior cingulate cortex. We see changes in the amygdala. We see changes in the prefrontal cortex. All of the exact same areas that are required for this human caregiving network. And so trauma has a profound impact on the brain in the exact areas that should be changing for the human caregiving network, making it harder for those changes to happen. Number 2, the brain areas impacted by postpartum depression and anxiety overlap also with these human caregiving network systems. And I think what's really fascinating to me is that this differs from generalized anxiety and major depression. So I have to say to you that for most of my career, people have been saying, you know, you have to screen for postpartum depression. And I got it that it was very common that 10 to 20% of postpartum women and men experience anxiety depressive disorders. But it was struck me like, well, why don't we screen for everything else? I mean, maybe they're not as common, but wouldn't it be important to know? And it turns out that it is really important to know about postpartum depression and anxiety because the neural profile of those disorders is these exact same areas critical to the human caregiving network. So think about that, right? So major depression, generalized anxiety affects parts of the brain that are not the same as the human caregiving network. So you're not in as much danger. Mother-infant interactions are most susceptible to disruption if it is postpartum depression and anxiety. Isn't that fascinating? Didn't know that before I started looking into this. So totally fascinating. Finally, the issue of substance misuse, right? The changes to the gray matter that we expect, which increase attunement and enjoyment of this caregiving, are hijacked by substance misuse. So number 1, the orbital frontal cortex, which is supposed to support that rapid orienting to the infant cue, doesn't develop or function as it should if there's substance misuse. And most critically, those reward pathways, which rely on dopamine and oxytocin, are disrupted. And I want to point out to you that in particular, there are certain substances which impact the nucleus accumbens and some other ones that tend to impact the ventral tegmental area. And the ones that are impacting impulse inhibition and the VTA are ones that ethanol, nicotine, THC, these are all legal in many states and are things that parents very commonly are turning to help them deal with the stress of parenting. And as it turns out, it's making it harder. And so I think that that's a really important lesson. I mean, we want to think about opiate misuse and cocaine misuse and amphetamines, but really some of the things that we consider legal and sort of, mommy's wine are really probably having a profound impact and making the whole thing harder. And so what we see when we have trauma or postpartum depression or substance misuse is what we call, and what is called in the field, disrupted caregiving. And what that speaks to is that we see frightened or frightening behavior from the caregiver. Again, they have this sense of fear, and they project a sense of scariness and fear. They have a lack of joy. They do not enjoy parenting. They have no intrinsic reward. There is impulsivity. They can't stay the adult in the room. And that leads to this lack of sensitive or responsive care. They're not able to provide reflective functioning. And overarching all of this are negative reactions and negative perceptions to parenting. Parenting is hard without reward, and it's super, super difficult. That lack of responsiveness really relates to the fact that the neural responses to child cues are altered. They cannot perceive what the child is trying to transmit from their own face or from the cry. This leads to a decreased motivation to interact, to breastfeed, to engage with the child. And even if they are able to engage, because of the prefrontal cortex impacts, we see decreased problem-solving skills. So again, parenting is harder. And what that results in is this lack and loss of attunement or synchrony. And what we see is that because of these changes, caregivers are likely to exclude outside supports. They can be much more intrusive with the child, but angrily so, negatively so. And that impulsivity is sort of what you might perceive in the visits that you have with a caregiver who's struggling this way in the child, right? They don't see parenting as rewarding. They have this need to soothe their own anxiety or craving, and that overrides their ability to parent. And they also have this cognitive resource depletion, right? They're so focused on craving or anxiety, and it leaves no resources for parenting. So what you might see are these harsh parents, these parents who, when a child's getting vaccines or when a child is afraid at the physician's office, instead of attuning to the child, instead of meeting the need and reading it right, they're either not able to read it, they're responding in a negative, angry way, they're not able to support that child. And so what that means is that attunement and synchrony, which a child desperately needs, it's their own social biofeedback so that they can come to understand themselves and the world, it's being ignored or misidentified. And so the child then comes to misidentify their own emotions and themselves. And we begin to see development derailing in kids when this is the case. And so I don't want to take you to this point and have you say, wow, Forkey, you know, like, thanks for the info, but now I'm more depressed than ever because, like, what the heck can I do about this? And what I would suggest is that further research gives us hope. So a researcher named Ed Tronick has done a number of studies looking at match and mismatch. So Ed Tronick did the study that it's called the still face experiment. I'm sure many of you have seen it, where the parent is playing with the child and then the researcher says, okay, turn away and don't look at the child. And the child tries desperately to re-engage the caregiver or the parent, and gets more and more distressed as the caregiver will not engage. And what happened as an outcome of all these studies was a much better understanding of that concept of attunement and synchrony and match and mismatch. And what it gets down to is, when this research first started coming out, what was thought was that the caregiver and the child had to be in sync all the time. And that's what was critical. But of course, that doesn't fit with life, right? Like, we're never in sync with people all the time. The phone rings, or we get a text, or we have to make a meal, or we have to go off to work. You're constantly matching up with the child and then disrupting. Match and disrupt. And it turns out that it is not so much in just the matching, but it is in the reparation. It is in the coming back together that a child really comes to understand themselves and the world and how to communicate. And so that gives us hope, because what we can do with caregivers who are struggling this way is we can think about ways to promote that reparation, to promote those opportunities, to build the fibers that allow for the reparation. And we don't have to get so hung up on the idea that they have to be in sync all the time. In fact, as research shows, the parent and the child only need to be in sync 20 to 27% of the time. So it's a pretty small percentage of the time. And so what we want to think about then is, okay, I have a lot to do as a pediatric provider. What do I have time to do? How can I prioritize of these fibers what I'm supposed to do? And I think what we can think about is that there's a little bit of a, like an order to them, that first and foremost, people have to feel safe. They can't be constantly in fear, having a sense of fight or flight, and they have to have truly feel that affiliate support, feel for themselves that this is a safe place for them to parent. And they have to have a sense of joy, because if you don't enjoy this ever, it's really hard to stay with it. Ultimately, you can then develop executive functioning and reflective functioning skills, and they all lead to this belief that I can do this job, that I'm going to be good enough at it. So when we think about what we want to do, we're going to focusing in on those first two, that sense of safety and that sense of joy. And so what we want to do is think about how can we help that caregiver to calm, help that caregiver to have a sense of safety so they can begin to reflect to the child accurately. So like just as water has to be calm to reflect accurately, so too does the caregiver. And we can begin to create those opportunities for the caregiver to do that work. I want to point out to you that you have a lot to do. So can you reflect to the caregiver? Well, you can as you're doing other work. You don't have to stop, do this, and then go on to do other things. We can do this work as we're doing the rest of our job. But we do have to keep some things in mind. What we reflect can certainly depend on our lens and our focus. And so we have to really pay attention to culture and context considerations, because if we misinterpret and reflect inaccurately, we may inaccurately cause caregivers to see themselves in a way that feels judgmental and is not accurate. The other thing that I think we need to be honest about is this concept of parallel process, that we looking at this behavior by caregivers, this disrupted caregiving with the impulsivity and the negativity and the lack of sensitivity. For pediatricians, that's tough. That's tough to watch, and we can immediately kind of rear up. And that response isn't wrong, but it does need to be sort of filtered through our understanding now of the brain and how much the caregiver has in their control. I think certainly in my work setting, we can kind of pile on, right? Like that when a caregiver is struggling and they are interacting very negatively with the child, we can make those comments. Have you seen that mom? She's really out of control, wow. And people can kind of say, yeah, she was really totally rude. Instead, I think what we need to do is remember that there's a biologic process that is keeping that caregiver from doing the work that we otherwise would expect to see, and holding each other accountable, letting yourself come out of the room, take a deep breath, talking to a colleague to say, hey, can you remind me about Human Caregiving Network for a minute? Because this mom is really going to need some help, and sort of supporting each other to kind of refocus our lens so that we can do that work. So with the few more minutes, I just want to talk about some techniques and strategies and resources to strengthen fibers in the work that we do. One of the things that happens when caregivers are struggling with trauma, mental illness, substance misuse, is that when you say, hey, well, can you tell me what's stressful? It's not one thing that's stressful. Everything is overwhelming. Everything is stressful. And so what we can do is begin to just create some safe moments in the office with us. What we want to do is reduce shame and begin to create a space for the caregiver to have those emotions and to know that it's okay to have those emotions. Claudia Gold has written some fabulous books about doing this work, and I would encourage you to read anything by Claudia Gold. But she calls this the stance of not knowing. This idea that we come into the situation and we really just want to explore with the caregiver kind of what their perspective is, recognizing that the relationship of the child and the caregiver is our patient. It's not just the child, but it is the relationship between the two. And the caregiver is bringing to the relationship their prior relationships, right? So we bring to parenting the way we were parented. And so there's a number of papers, first about ghosts in the nursery, this idea that someone who is raised with impaired infant-parent relationships will bring those impairments forward, that's what they know of caregiving, and so that's how they do kind of draw that into their own caregiving. Alternatively, there's this concept of angels in the nursery, and this is Alicia Lieberman's work, that intergenerational transmission of benevolent parental influences is just as significant. And so We can take the stance of not knowing, asking caregivers, how were you parented? How do you want to parent this child? What does the child's behavior mean to you? Because I'll tell you that parents who are struggling will often assign meaning to child behavior that is really related to their prior experience and is not accurate in terms of what's going on with the child. I do child abuse work, and not long ago was sitting with a caregiver and the 9-month-old baby who was kind of trying to crawl and kind of got on his back and was kicking around in the crib safely while we were talking. And this was a baby who had been admitted because he had bruising, and it was a concern for physical abuse while he had been in the care of mom's boyfriend. And I was asking her about, how the baby's behavior was and what was her understanding of how, what the baby was doing. And she said, you know what, he's just violent, just like his dad, meaning the boyfriend. And I said, really? He's violent at 9 months? She said, yeah, look at him. And she was assigning that violence from her experience with the male figures in her life, including this boyfriend, to the infant's neutral behaviors of just, exercising and moving his legs. So again, that trying to hold the caregiver in mind and look at how this relationship is being developed in their space. So clearly this caregiver herself was struggling with her own postpartum depression, which I think was also impacting her ability to understand. The other thing that we want to do is begin to try to help caregivers to recognize what are their affiliate supports in their life. Because when we talk to caregivers who feel this way and say, well, who can help you? They'll say, nobody. There's nobody who can help me. I have no one. I'm all by myself. And many people are struggling without the sufficient relationships that they need. But what we can do is we can begin to identify even people who are just in their immediate vicinity who can begin to start with that feeling of sense of support. So what we'll say is, suppose something happened in the middle of the night, right? So that there was, a house fire or an earthquake or a tornado. Who would you call in the middle of the night? Is it a neighbor downstairs? Is it a relative who lives in town? Is it a friend that lives across town? Is there somebody who you would call in an emergency? And usually people will identify that there is at least someone that they could call in an emergency. And we say, okay, great. So there's one person. Now, suppose it's the next morning. Who would you call to help you because you needed new housing or you needed to find food to eat or whatever? So this begins to expand that idea. Is there someone from the faith community that you could call? Is there somebody who has worked with you in terms of resources at daycare or a pediatrician? Who is in the broader community that can help? It is important to think about who specifically could help with one particular child, right? So if it's a problem you're having with this child, is there someone who knows that child better? Is it an old babysitter? Is it a teacher? Again, is it a pediatrician who can help to specifically brainstorm with this parent about that one child? It is also important to talk about who to avoid, because often for people who've had experiences with relationships that are not healthy, they can go back to them in times of stress. So identifying that the abusive relationship, not to go back there, that if there's a parent that wasn't supportive, to not go back there, but also to avoid using older children who are in the household and putting adult pressures on kids to parent just because they're the older kid in the household. So having some discussions about who can help and doing this social mapping. The next thing is that we talk about play. And all right, I have to tell you, I was a really slow study on this one. People started to talk to me about play, and I was for many years was like, blah, blah, blah. Everybody knows how to play. No, everybody does not know how to play. If you think about how you play, if you're if somebody's running into traffic, you of course can't play. And for people who are constantly under threat, they have never learned to and don't feel safe playing. Because as it turns out, play is not something that you can do when you're constantly fearful. However, if we can reduce that sense of fear a little bit, play does promote and help you recognize safety. And what having the opportunity to do imaginative play does is it allows kids and caregivers to increase trust and joy and this sense of safety. They can recreate relationships, they can recreate scenarios and play them out in healthier, safer ways. So what we may want to do is talk about this dyadic co-regulation and prescribing special time in. You guys, this is a little bit different than time in, but special time in is sort of saying to the caregiver, you know, we want the child to pick an activity, and you pick the time when in your day you can do it, and set the timer for just 5 minutes, and you are going to just focus on the child and do that activity, focused in on them. When the timer goes off after 5 minutes, you're done. But you always want to follow up with the caregiver, because what we often hear is that, hey, the 5 minutes was fine, the kid did great, but after that he was worse than ever. And of course, what we know is that the child has felt a little bit of that biobehavioral synchrony, which is exactly what they need, and now they crave it, and they're going to get noisy in kind of demanding it. So some of the things we can talk about is, how do we expand the opportunity for that, find other opportunities in the day, or for a caregiver who's especially struggling, thinking about setting it as a routine, so the child knows when to expect it, and the caregiver knows that, you know, I just have to get through this particular point of it. Because what you're building is the sense of safety, and you're starting to build for the first time joy and that opportunity to enjoy each other's company, which will be new to caregivers. They may need guidance on what play looks like, because not all play is the same. We're talking about things where play is face-to-face, talking and smiling with each other. Not long ago, I was talking with a dad who had just recently got his son back. His son had been in foster care. And I said, so do you guys have the opportunity to play? And he said, yeah, he's lots of toys. I just put him in the room and he plays with the toys. Well, of course, I didn't want him to just play, but I wanted them to play together. And when I sort of said, well, do you do things together? He said, yeah, all the time. I said, he said, I put him on the ATV and we go for a ride. Well, the child was 3, so that made me a little nervous on the ATV, but it was also not what I meant, because we're talking about this interactive play. The other thing that sometimes caregivers need is to promote the P's and avoid the Q's. And so the P's are praising and paraphrase and pointing out, wow, you are drawing such a great picture of our dog. I can see that looks exactly like our dog, but is that me right next to the dog? That praising, paraphrasing, pointing out builds that synchrony. Caregivers who are struggling will often feel this need to lead, question, criticize. And so what we'll hear is, don't do it that way. You're doing it wrong. Stop doing it that way. Do it this way. And what we want to talk to caregivers is about, you know, like, let's try to avoid those cues and do more of the P's. There's some great 5-minute activities from ARC, which is Attachment Regulation and Competency Therapy. And what it points out is that many things can be done in 5 minutes, and they don't have to be elaborate, right? You can even unload the dishwasher together in a funny way, or pray together, or, you know, blow bubbles together. And these are just these sort of simple opportunities to connect, set the timer, and stop. When we talk about this regulation, we're talking a little bit first about relaxation, then making the connection, and then doing something about feelings, identification, and expression. Again, caregivers who have not been able to identify their own feelings may not be especially good at doing that with kids. And so we can build in some very specific ways to do that. For the relaxation, I don't really have to give you guys a lot of you know, information about this. We talk about, you know, opportunities for relaxation and yoga and meditation. There are plenty of apps that they can do with kids. Having a list of them so you can provide that for caregivers, helping them to find it on their phone so that they can find one that they're comfortable with and can go to with the child, depending on the age of the child. But then also teaching them techniques to do some co-regulation, right? There's things where they label feelings, where you watch a video or a TV show and you identify, what is Kim Kardashian feeling right now? What is the emotion? They can do things simply like breathing together or body calming, doing sort of the relaxation, you know, first relax your toes, then relax your ankles. Backstories is a fun one, where the child draws a story on the back of the parent, and the parent has to try to figure out what the story is, and then the parent does it for the child, and they try to sort of tell each other a story that they've drawn. Listening to music together, other sensory activities, all ways for you to get in sync. And ways to promote synchrony, you know, there's actually whole papers on this. And what we know is that when we think about synchrony with an infant, we're looking at that gaze of the parent, the rocking, the singing, that affective expression that I talked about before, that oohing and that eyeing. Then when the baby goes, ah, and the caregiver goes, ah, you know, they're matching. They're exclaiming together, and you're having these exaggerated body movements where the caregiver is really syncing with that infant. You can do this with older kids too, marching together, dancing together, storytelling together, chanting or praying together, singing in unison or in harmony, shared motions like rowing together, even having a discussion of what we have in common or what are our holiday traditions. All of those things allow us to get into this biobehavioral syncing, even with kids as they are older. I will say that there's some other creative opportunities out there. Mind reading stethoscope is a fun one that you can try. Again, for older kids, I often have adolescents who come in and talk about how the caregiver has no idea what they're thinking. They don't know anything about them. And I have parents who say, they don't understand how hard my job is. They don't understand that I'm worried about them. And so we talk about the mind reading stethoscope. I have a pretend stethoscope, or I even use my regular one. And I say, hey, if I put this on mom's head, here, you go ahead and do it. What do you think she's thinking in those moments when you're most frustrated with her? And have mom put the stethoscope on the kid's head and say, what do you think he's thinking when he's acting out this way? What do you think is going through his head? And it allows that opportunity to kind of get the mind in mind. Think about it from the other's perspective. One last one is role playing and switching, right? You have to pick whether the caregiver and the child is really going to be able to do this without being too negative or snarky. But for some caregivers and kids who've especially come in after a blow up or a tough time, having them reproduce the event or the incident where they play each other's roles, talking out loud about what they were thinking as it happened, so that the parent has to be the kid and talk about what they were feeling and thinking as this event happened, and the child doing that for the parent. If you have the opportunity and time to do that, it can be very powerful and very useful in this opportunity for syncing. So in summary, we've talked about the fact that the affiliate response is a way kids manage stress in the healthiest way. Attunement, biobehavioral synchrony, and co-regulation are the pieces underlying the benefits of safe, stable, and nurturing relationships. Traumas, stress, depression, substance misuse can result in impacts on brain systems needed for caregiving, particularly a sense of safety, reward pathways, executive function, all of which impact the abilities of the caregiver to attune, provide that biobehavioral synchrony, and co-regulate. Our parallel process can impact our own ability to provide care, and if we address it, call it out, that can help. Coming to patient visits with that stance of not knowing and without shame can help support caregiver sense of safety, and then we can move on to promote play, relaxation skills, role play to support that intrinsic reward or joy of parenting and reflective functioning. I do have some sort of very particular things you might want to think about is consider discussing with your partners like how you can respond to caregivers who are struggling with safety in the medical setting. Make up some resources to have on hand to guide simple play techniques for caregivers, and think about a team strategy when a caregiver is struggling and you're getting triggered in that parallel process as well. I have a bunch of references, and I'm also happy for us to just spend the rest of the time chatting.
Thank you. That was super interesting. There was a question quite a while ago. It was in the photograph that you had of the mother with the baby and then the male figure with the younger child. And Amber had asked, when you were talking about the biobehavioral synchrony, how that related to the question of nature versus nurture.
So I'm not sure which nature versus nurture she's thinking about. I think what it points out is the fact that we are wired for this biobehavioral synchrony, but there are multiple ways that we feel it, right? It's not one opportunity for syncing, and is not one way to do it, and that in caregiving relationships, we achieve that sense of synchrony in different ways. The research that was done in sort of traditional maternal and paternal. A lot of the research has been done in Israel. Interesting studies that are in my references are totally worth reading. But I think what it points out is that feeling that sense of synchrony doesn't have to happen by a female caregiver holding a baby, right? That it can happen by a male caregiver or a caregiver who's acting in a way that sort of syncs in a different way. It doesn't have to go along gender lines, but that there are multiple ways to have that sense of synchrony. But that we learn different things about ourselves and about the world through different types of synchrony. So I would point out that we have the neural network, so maybe that's the nature, like we have the the biologic capacity for this syncing. It is a critical factor. And what's interesting is that when you look at evolutionary studies, these neuronal pathways evolved along with the hormones of oxytocin and vasopressin, which came along so that you could have, we used to have like eggs and, like in order to have birth through the womb, you had to have this oxytocin, but you were going to have a baby born well before the neurologic system was completely developed. So you had to have this opportunity for this external regulation of the child for development. And so that's probably the nature then supported by the nurturing in different ways by different caregivers. Although maybe I have not answered the question at all as it was intended. So feel free to correct me.
No, that was good. Thank you so much. I just wanted to ask one other question if I could. I am a lactation support person as well. And so I'm just wondering, hearing all of the amazing things, right, that oxytocin does and plays a role in at different stages of life. I'm just wondering if there's a push to, have pediatricians have more access to lactation education as part of, their, or maybe you, I don't know if you have any lactation certifications yourself, just because, right, oxytocin seems to be playing such an important role. And is there a study or research showing that, like, if we have more, breastfeeding promotion, would that also be something that could help with these different like emotional regulations down the developmental path?
Yeah, I mean, I think that's a great point. Certainly, I think there's a whole host of effort around promoting breastfeeding for, the nutritional reasons and the emotional reasons, but certainly this is a significant piece of it. I will say it's not the only way, right, that we see that there's paternal connection this way, and there's connections with caregivers who adopt or, are not breastfeeding, but you're 100% correct. Through breastfeeding, you have this physical biobehavioral synchrony, right? The body of the breastfeeding parent is completely in sync with the infant. And there's some really cool research. I have to find, I will look for the paper, but there is one of these studies looks at what is happening in the latching on process, the breastfeeding, and then completing breastfeeding in terms of how the syncing is changing and how the parent and child, they've studied some of the hormonal and behavioral matching that happens throughout sort of a breastfeeding cycle. And so there's some really very fascinating research. And I think this also points out, but I have to say, you said, is this why we should promote it? I have not heard this as a good reason why we should promote it. I've heard a lot of the nutritional reasons, and I've heard, it's emotionally good for the baby, but not to this level of understanding. And I think for those of us who work in pediatrics, it's really helpful to understand the science. Like this is not insignificant. The brains of humans change remarkably. And if we have opportunities to promote things that help it to change in a way that's going to promote parenting, why would we not want to know that? And why would we not want to share that? So I 100% agree with you that this is something that we should be paying more attention to and talking about more. And if I can find that article, I will send it to you, because I probably completely misquoted it as well. When you read things and you're like, oh, that's totally cool, I'm totally gonna remember that exactly. And then you kind of botch it for the rest of your life. So I'll find it, I'll send it to you.
And I do have the post-session questions going for those of you who want to get started.
And if we have any other questions, we do have a couple more minutes. Folks, feel free to drop questions in the chat or unmute yourselves. I do have one question that I was wondering about with some of those tips that you were talking about at the end to kind of promote, to sort of reduce the fight or flight response and to promote attachment and so on. I wonder if you have any specific phrases or body language that you can recommend that enables us who may be living a very different life to kind of increase the like the power differential that naturally happens that can make folks feel judged or defensive or attacked when we try to bring up comments about maybe more wholesome ways to parent. I think that can be really challenging.
So this, I think, is also a really fascinating piece of neuroscience that we don't get trained enough in. So I love that question. So there's a whole study of what's called neuroception, which is a phrase which is used to explain how we perceive threat, even when we're not conscious that we're perceiving threat, right? So if you were to sort of have lights flash or a funny smell or to hear something weird, your attention would immediately be drawn to that because we're constantly scanning the environment for threat. When we have families come into a medical environment, they are immediately perceiving threat even before we've gotten involved with them, because people perceive threat through sound. Low pitched sounds are sounds of danger, right? So if you like listen to the Jaws theme, doo 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 doo, it's low pitched because musicians know that that's the sound of danger. High pitched musical sounds are sounds of safety. And so the kindergarten teacher talks to children, "Hi, children, welcome to school today." That is called parent ease. So if you can start by even taking the register of your voice, not sounding like the kindergarten teacher, because then people think like they're talking down to me, but consciously taking the register of your voice. So when I encounter families and start to walk in the room, I'm thinking about my body language, but I'm also thinking about how it is that I first present. Like we tend to kind of go in and sort of have a kind of low pitch sound. You want to have sort of, "Hey guys, I'm so glad you've come. This is phenomenal. I'm really glad we're getting the chance to talk about it." Matching affect is important too, right? So if the parent comes in and they're like, "You wouldn't believe how frustrated I am. This kid is out of control." And if I do sort of what HR representatives suggest that I do, which is say, "Oh dear, I'm very sorry to hear that," with that neutrality, parents are going to go like, "She is not hearing me," because we feel heard when there's affect matched. Wow, I can totally imagine why that is so frustrating. And I am so glad you brought it into us, because here is exactly where we should be talking about it. You match the affect, you bring the tone up high, and you'll walk it back, right? You take the anger out, you'll walk it back. So there's some very simple little things that you can do. Like there's a whole sort of host of science things you can do about that. But then you get into that concept that Claudia Gold brings up, which is that stance of not knowing, where we ask more questions than we sort of perceive and sort of say, "Hey, you brought up that his behavior is totally out of control. Can you tell me more about when you're noticing that or what's going on?" Really truly recognizing that they understand the situation better and you don't. And also asking them, what do you think is the meaning in that behavior? What do you think he's trying to tell you? Since we know, most of the time kids are trying to tell us something with their behavior. Do you think he's trying to tell you something? Kind of opening it up for those kinds of questions. Why would you think that? Why would that be so? Those are all those opportunities to sort of take some of the, "I know best, do it my way," when of course we don't know best, we don't know the situation, and we can create those opportunities. I also don't want to sound like Pollyanna. It doesn't always work. But if you've created that opportunity, sometimes people will not respond immediately, but come back to you because they do feel and hear in you this sense of openness and willingness to discuss it. So there's no one answer, but I think some of those are some sort of easy little tips.
Thank you, Dr. Forkey. Could you just go over number 2, the quiz question number 2? A number of brain systems change as part of the human caregiving network. These include all except. That was the only question that there were a little bit varying answers.
So that's the fibers, right? Fear versus safety, intrinsic reward, reflective functioning, beliefs that you can do this job, and executive functioning, which I've done out of order. So those are your fibers.
Thank you for doing that. And thank you for a wonderful talk. We're a couple of minutes over. So I think we'll go ahead and wrap things up. I want to remind everyone that next session will be suicide prevention with Dr. Deborah Gobert. And we're really looking forward to that as well. For now, I'm going to say thank you so much. I think we all learned a lot, lots of thank yous coming through in the chat as well. And not only from physicians, there's a very multidisciplinary group here. So I think we all got a lot out of it. We're really grateful for your time, especially at dinner time. And yep, there's a clap. So same for me. Thank you. Excellent.
thanks.
Slides are
Thank you.
posted on our website.
Take care.
Thanks, everyone.
Okay, bye everyone. See you in 2 weeks.